Liz Hammond, we're meeting here today to recognize your award for a pioneer in heart transplantation from the International Society for Heart and Lung Transplantation. Congratulations, Liz.
Thank you very much, John.
Well, before we begin, I'd like to embarrass you by talking a little bit about your history. And then we'll jump into some of the questions about your career, your life, and your interests. Dr. Elizabeth Hammond is professor of pathology at the University of Utah School of Medicine and chair of the Department of Pathology at the Latter-day Saints Hospital. She did her postdoctoral fellowship in tumor biology at the famous Karolinska Institute in Stockholm, Sweden, and her pathology residency and research fellowship at the Massachusetts General Hospital in Boston. Dr. Hammond subsequently spent 2 years as an assistant professor of pathology at the Harvard Medical School. She spent the last 34 years at the University of Utah and is world-renowned for her pioneering and continuing work in the pathologic humoral immune response in heart transplant patients. She has authored more than 125 original peer-reviewed publications and 14 book chapters. Among her distinguished achievements, which are many, she was awarded the Pathologist of the Year Award from the College of American Pathologists, past governor of that entity, member of the Board of Trustees of the Intermountain Healthcare System, grant reviewer for National Cancer Institute, recipient of the Heart-Lung Institute Legacy of Life Scientific Award, and Distinguished Alumni Award from the University of Utah, among being on the editorial boards of many prestigious publications. Well, Liz, your work in the humoral response and antibodies has been tremendous, and certainly has been one of my interests. So yet I feel like we have a bond together, and certainly this will be a great thing to discuss.
It will.
But before we begin on that, tell me the reasons you went into pathology and eventually transplantation.
The main reason was that when I was in medical school, my sister, who was living in Germany at the time, was found to have progressive renal disease. And the doctor that was treating her said she was going to die of that disease. But a mentor I had, Dr. Bloomer, felt that they were probably wrong. We got the slides and looked at them and found out that she had lupus. That convinced me, because I loved her so much and I wanted to help her, that I needed to do something to understand the body's immune responses. Dr. Bloomer was a principal investigator of a clinical trial of Imuran. He managed to treat her with Imuran. Her renal disease went into a complete remission, and although she had huge numbers of exacerbations and remissions over her life, she did live to be 68 before she succumbed from her disease. So really, it was because of my sister Kathleen that I became a pathologist, and specifically an immunopathologist.
Well, we're very glad for that. And how was your experience at the Karolinska Institute in Stockholm, Sweden?
That was an amazing experience. I worked with George and Eva Klein, who were pioneers in the evaluation of virally induced tumors. And through their lab that year I was there, very famous immunologists came every week to lecture and to be able to spend a little time with them. So I really had a wonderful experience learning about immunity at their feet. It was a great experience.
Well, that's where you get your background in immunology. Okay,
it is.
I understand that. You mentioned to me just a while ago that you really, truly love Boston. Now, you were in faculty at Boston. Tell us a little bit about that experience.
Well, when I was in Boston, I got to meet Hal Dvorak right away. As soon as I got there, Hal was a young associate professor doing immunopathology research, very interested in the role of macrophages. And so I was his first postdoctoral fellow. And I learned a huge amount about endothelial cells, endothelial cell biology. He was the person who described vascular permeability factor, which is better known now as VEGF, vascular endothelial growth factor. But I learned a lot about endothelial biology by being in Boston. It was an amazing experience. And it was fun to just be in that environment where there's so many medical experts. You can always find someone to answer any question you have. It was really a marvelous opportunity to learn.
And you'd still be in Boston if your family didn't pull you back to Utah?
Absolutely. I would have never moved to Utah again because when I was in medical school, I had a lot of difficulties being a woman medical student. It was not a very pleasant experience at the time that I went to medical school, and I never wanted to go back there. But my husband's an architect. He was offered a full partnership. And so because I thought I could probably find a job doing the things I liked, as a physician in Utah, I agreed to go. And it turned out to actually be a very positive experience for us.
Mm-hmm. Well, you touched upon a question that I was going to ask you later, but why not now? As a woman in medical school, I don't want to say many years ago, but perhaps
Really
a few years ago.
Yes.
How was that experience, and how did you deal with it?
It was a very difficult experience. So many people told me that I would never get married, that I would never have children. When I applied to medical school, I had excellent grades and excellent test scores, but nevertheless, I was expected to have a third interview with the head of the psychiatry department, who told me I was taking the place of a man in the class, and did I ever intend to get married, and did I ever intend to have children? And I responded with a smile, just kept looking at him and saying over and over again, Dr. Bliss, I intend to practice medicine my entire life. I'm really sorry Dr. Bliss is no longer alive, because I could say, guess what? I did practice medicine my entire life. I was in love with my husband at the time. We were planning to get married, but I knew that if I told him that they might not let me get in medical school. And the faculty were really very difficult. The students, however, we bonded together really tightly and helped each other through that experience. So I became very close to my fellow medical students.
And I dare say that you have become a tremendous role model for many women going into medicine.
I think I have, and I've reached out to them every chance I get to tell them that, they're not crazy, that they can do it, and that they should ignore those criticisms. My parents said a wonderful thing to me. They, when I was a young girl saying I wanted to be a doctor, they'd say, well, you can have anything you want if you want it bad enough.
Well, that's a great deal of recommendation for your family as well.
Yeah.
So as you continued in medicine, did you have mentors that truly led the way for you, aside from the early mentor you spoke about?
Yes, I did. It's fair to say that all along the way I had people like that. A high school English teacher who taught me how to write, a professor at the University of Utah in comparative anatomy who convinced me that my husband would love me even if I wanted to be a doctor, and told me, you shouldn't give up your dreams for some man. You need to just let him know that this is what you intend to do. When I got to the Mass General, I got to be friends with Dr. Castleman. And Dr. Castleman, who's head of the residency program, taught me a lot, because he believed that pathologists had to be clinically responsive, and told us over and over again, if you don't write a report that helps the doctor treat the patient, then you don't deserve to call yourself a doctor. And that was very profoundly influencing to me. When I moved back to Utah, I met a number of very wonderful colleagues in cardiology, Jeff Anderson, Brent Muhlstein, who I got to do collaborative work with, people in cancer who the LDS hospital was a great place when I moved there in the early 80s, because there were all these young professionals who wanted to do research, and they were all there just anxious to collaborate. And so I had many wonderful experiences from dealing with people that wanted to work to collaborate together on projects, including the heart transplant team.
Mm-hmm. Well, let's get into that aspect. I mean, your interest in the humoral response, antibodies.
Right.
How in the world did you think about antibodies at that time when people were not even thinking antibodies existed in terms of the rejection response?
Well, I was a renal pathologist first. When I learned to be a pathologist at the Mass General, I had to have a field of expertise, and because the most logical one for someone who's interested in immunopathology is renal pathology, as well as cancer pathology, dealing with the other side of the immune response. So I became a renal pathologist. When I got to Utah, I was the renal pathologist for all the hospitals there. And renal pathologists know that antibodies cause disease. And in renal transplant, in the 70s, it became obvious that that antibodies caused renal disease for transplanted patients. So it seemed logical for me to apply the same tools to heart biopsies when I got to look at them.
You know, we're glad you actually went in that direction, because currently antibodies are being viewed as being the culprit,
Right.
perhaps in chronic rejection in not only heart, but
Right.
all organ transplantation.
Yeah.
So certainly your work has pioneered and paved the way for other work to be done as
Right.
well. Now, the International Society for Heart and Lung Transplantation, you know, began way back in the early 1980s. Do you have recollections of the first meeting you went to, and who was there and what happened?
Yes, I do. The way that I found out about the Heart Transplant Society was through Margaret Billingham. When I started looking at heart transplants and finding this process of antibody-mediated rejection, I reached out to her to find out what she knew about it. And she and I became fast friends. She invited me down to look at her slides in her lab, and I found slides that I felt showed antibody-mediated rejection, which we couldn't prove because the special studies had not been done. But she recognized that they were somewhat different than the usual criteria, and persuaded me that in 1990 I should go to a heart transplant meeting. She said it was the place to go if you wanted to be with all the transplanters and find out what was going on. So I agreed to go. And then the next year, she put me on a panel to develop the rules for grading acute cellular rejection. And after that, I started coming to the meetings regularly. I remember it as being a much smaller society with a lot fewer people, and walking around, you could basically get to know anybody that you, or see anybody that you knew. Especially the cocktail receptions seemed like they were quite small, sort of family gatherings almost. At that point, because there were so many fewer people. Now I go to one of those cocktail parties, I can barely find anyone because I'm so short. I can't see anybody.
I share that with
Yes.
you, Liz. I have to get
Right.
boosted up to see who's
Yeah.
in the crowd as well.
I can always find Jack O'Connell because he's nice and tall.
All right, well, you brought up Jack O'Connell's
Yeah.
name. Okay, let me get into that. You know, back in the 1980s, the Utah Heart Transplant Consortium
Right.
was tremendous. You
It
were
was.
the big boy in the block. You were the 6,000-pound gorilla,
Right.
you know, doing over 100 transplants a year.
Right.
And you had the triad of
Yes.
Mike Bristow, Jack O'Connell,
Right.
Dale Redland. These
Right.
are huge names in cardiology.
They are.
How did you deal with them?
Well, it depended on what I was dealing with them about. Mike Bristow, you know, was trained at Stanford, and so when I started saying that these people that were dying with no rejection really had a different form of rejection, at first I think he thought I was crazy, but he started listening to me and ultimately came to believe that I knew what I was talking about, which, to his credit, I mean, he although he thought initially I was wrong, he came around quite quickly. And then he got Jack to join him, and Jack was a wonderful clinician and provided the sort of calm, peaceful side of the program that we needed. Dale was the consummate clinician. He was a wonderful physician who liked to treat patients and was very astute at figuring out what was going on with them. So the three of them made an absolutely killer team. And you needed all three of them in order to get along with the transplant surgeons who didn't get along as well as they did all the time. And
Well, that's
it was
usually the
very
case.
helpful.
Yeah.
Yes, it was
Now,
very
did
helpful.
you ever have any conflicts, any disagreements with any of these cardiologists or surgeons?
Well, the surgeons had a lot of conflicts with each other, and but I think Mike and Jack and Dale managed to work those out. What I think was really amazing is that Mike had the vision right away that if we didn't have all those hospitals working together, because Utah's a small sort of provincial place, that our program would fall apart. And so he and Jack was a wonderful politician about dealing with these people and helping them get along. And so I think that using the three of them, they managed to hold the program together even when difficult things happened. And they didn't share much about what those difficult things were. So.
Well, you certainly were quite successsul. Not
yes,
only
we
did you
were.
do a lot of transplants, but you had great outcomes as well.
Oh, we did.
Yeah.
I began keeping track of the data in a database right from the beginning. And that really helped us because we could go back and say, okay, well, have we had any other patients like this who had the same kind of problem? What happened to other positive cross-match patients? What happened to other people with this particular thing? Do the patients with idiopathic dilated cardiomyopathy do worse than the ischemics? And they had very good memories of these people. I would write all that data into the database, and so we could use that data to help us deal with issues that we faced.
So that was your secret,
That
getting
was one of
together
them.
your database.
Yeah.
You know, you were pursuing antibody-mediated rejection when the rest, or I shouldn't say the rest, but many people in the country even debated its existence.
That's right.
And I remember some rather heated discussions in terms of pathology
Right.
meetings about that. How did you deal with that?
Oh, often not well. I was publicly rebuked at the heart transplant meeting in Italy, where people actually in the audience got up and said that they thought that what I was doing was something that probably only occurred in Utah or only in people treated with OKT3, and that I was basically wrong and was misleading everybody. It was a very upsetting experience. Actually, after that happened, I stopped going to the meetings for a couple of years because it was so painful to me to come. But I didn't stop believing that I was right. And so I kept working with the data. And luckily, the doctors and nurses and professionals in Utah all believed in what I was doing, and we continued to treat our patients as if this was real. So as long as I stayed home with them, I was fine.
You know, I really think, though, it had to do with your volume. If you
Yeah.
do enough patients,
Yeah,
you'll see this
that's
entity come back again and
Right.
again. If you only do a few transplants, you may see one and may debate whether or not it was really something at all. But
Right.
the fact that you had so many patients, you were seeing the issues coming back, and perhaps the OKT3 had something to do
Oh,
with
it did, no question.
Yeah.
Because when you induce people with OKT3, you accelerate their immune responses, especially the humoral ones, because they get these anti-idiotypic antibodies. So we showed that those responses are markedly accelerated in the presence of OKT3, and in fact we could get the incidence of antibody-mediated rejection down if you only treated people for 7 days. But at the early days of the program, Mike Bristow was trying to tolerize people with OKT3, and he even treated a few patients for 21 days, which meant that they really got anti-idiotypic antibody formation.
Wow,
And
wow.
it took 3 different publications and a whole bunch of colleagues working with me to prove that that was not a correct assumption on his part. But he believed me when I showed him the data. I mean, I think one of the main reasons why we kept seeing this is that I had longitudinal follow-up on these patients, and we were not just looking at anecdotal information from one biopsy. We could show what happened to a patient over all their biopsies because it was all in the database. So did they have 3 episodes or 20 episodes or 0 episodes?
Now, was that one of the reasons why the OKT3 was being less used after a while?
Oh, yeah.
Was it something that you had discovered and talking to the cardiologist decided to cut
Right.
down on it?
Well, yes, and we published a paper where we showed that if you cut the dose down to 7 days, that this process would not occur anymore. First, they cut it down to 10, and then they cut it down to 7. But I was showing them the data all along and publishing the papers, and they believed me. So.
Well, you may not know this, but actually the world was looking at you at that time.
Yeah.
We all didn't quite know about OKT3,
Yeah, right.
whether it was beneficial or not.
Right.
And everyone would always point to Utah and say,
Yeah.
Dr. Hammond and the crew there
Yeah.
pretty much know what's going on. So whatever you all did, we did in the rest of the country.
That's good, because it was a dangerous drug. I didn't have the same kind of luck with the liver transplanters who believed that they could just keep treating people with it. And they had some serious poor outcomes related to that, because the liver clears antibody much more effectively than the heart. The heart doesn't have the reticuloendothelial system, so it doesn't clear antibodies, and you can get away with a lot more humoral immune response in a liver transplant than you can in a heart. And so it took them longer to figure it out.
Well, just talking to you, we're going through the history of heart transplantation now, and going to what we believe to be in the past, and of course no longer believe at this point in time.
Right.
Well, let me shift gears a little bit here, and we had several international meetings.
Right.
The meeting that I recollect was the 2003 meeting, when we met for the first time in terms of revising the ISHLT grading scale. And to my recollection, that was quite an interesting and heated meeting per se.
It was.
What were your recollections about that meeting?
Oh, we had just had that NIH meeting on antibody-mediated rejection. We believed that, it was obvious at the NIH meeting where you were the chair that clearly antibody-mediated responses were causing harm in every other kind of transplant. And those people who were in the room at the NIH meeting also agreed. So I was quite surprised when we got to the heart transplant meeting and had individuals just saying that we have to do nothing but deal with cellular rejection again. It was very frustrating, and I think if you and others in the room who were clinicians had not stood up and forcefully stated that this is a problem that is hurting patients, that they are dying of this problem and not cellular rejection anymore, we have effective drugs for cellular rejection. I don't know if we could have turned that around. I think we really had to have a mixed meeting like we did with clinicians with us, because otherwise it probably would have just gone the same way it had before.
I certainly remember you standing up and pushing this issue.
Right.
I remember too, it was getting quite heated, as I recall one pathologist, not you, threatened to walk out of the room because of perhaps some untoward comments that were made. But certainly I think that was a pivotal time in terms of heart transplantation, where certainly your work in pathology paved the way to prove that this antibody-mediated rejection actually existed. So I think we owe you a great deal in terms of having our patients get better because of the work that's being done at this point in time.
I think a lot of, Susan Stewart was the head of the pathologists at that point, and I think she recognized, to her credit, at that moment that there needed to be, that somebody needed to pull this together, and I think she was very good at doing that and at least getting into the guideline what was required. So that we could then start moving ahead. And that led the way for the Europeans to start seeing antibody-mediated rejection as being something real, where they had not been players in this before. And I think that shifted their thinking in an important way.
Are you currently pleased the way the society and your area of expertise is going at this point?
I'm thrilled to see what happened. In 2010, when we had that great symposium where we talked about antibody-mediated rejection, the pathologists had a very lively meeting. It was only 2 hours long, and we couldn't accomplish everything in that meeting. But there again, the Europeans, because of the problems with air travel, mostly were in Europe at the time, and they still on the phone said, look, we've looked for this, we can see it now, we have to come to agreement. Which yesterday we had another meeting about the same subject. It was really a fruitful meeting. Everyone was really collaborative, trying to work together to solve the problem. And I feel strongly that we'll get a standardized scoring system for antibody-mediated rejection.
Well, it must be quite satisfying for you, to come all this ways and the dark times, when nobody believed that it actually existed. Well, looking back upon your career, Would you do anything different?
Oh, probably not. Probably not. I don't think that I could have impacted. I think time had to go by. I don't think that I could have changed. I could have changed the circumstances by anything I did. And when when this whole process was going on, and the world did not believe me, the people in Utah did. And so our patients we learned a lot about the process by doing our work in our own system. I think there's great power in having a collegial group of people who you can work together with every day. And because I've had that, I really wouldn't change anything.
So life in Utah sounds like it's been pretty good to you.
Oh, it has.
Did you acclimate very well from Boston to Salt Lake City?
You know, the 10 years I was gone for 10 years. When I got back, it was not, the situation for women was very improved. I was one of 2 doctors on the medical staff in Utah when I arrived, out of 1,100 doctors. But in 1996, I was elected as the medical staff president by those male doctors, and considered to be one of the boys. And so I really feel like the circumstances changed, and I might have had something to do with that. They elected me the chair of my department. They found out that women could do the same. You know, that you don't look at whether somebody's wearing a skirt or a pair of pants, you look at what they can do. Mm-hmm. And so in that way, it was very satisfying.
I think to prove your point in all this too, that you certainly were able to do your work, you had a family. You raised a family. Tell me about that, Liz.
Yes, I did. It's mostly to the credit of the children and the husband I have. But my husband was wonderful. He's an architect. He knows nothing about medicine. We got married when he was in architecture school and I was in medical school. And I became discouraged because I looked around at my friends and they were all working so their husbands could go to school, and I was going to school too. And so I said, well, you know, maybe this isn't going to work out. It's going to be hard for us. And he looked at me and he said, this is our life, and we have our own experiment in life, and we are going to do it. He didn't say, I will support you. He said, we are going to do it. And that's really the spirit he's brought to our whole life. I mean, he has been very much a partner in raising our 3 children, and so have they. I mean, they recognize this was something that their mother wanted to do, and they've been very supportive of me the whole time. So but on the other hand, I would not go through life with no husband and children. I'm so grateful I have them. Mm-hmm. They are my crowning achievement.
And what are they doing? How old are they?
My oldest son just turned 40. He's a master's prepared engineer working in sensor design in Greensboro, North Carolina, and he has 5 children, just darling little children. Then I have a son, Tom, who's an ENT physician in Fairbanks, Alaska, and he has 3 children. Then I have a daughter in Seattle. Her husband works for Microsoft, and she's an urban planner, a historic preservationist and urban planner. She's staying home and raising her 3 children. So I have 11 grandchildren, which is just
congratulations,
wonderful.
Liz.
Thank you.
That's quite an accomplishment by itself.
Yeah.
A lot of presents to get at the holidays.
Right.
All right. So what are your hobbies? What are your interests aside from medicine, aside from your family?
Well, it's hard to have, when the grandchildren are around, it's hard to have any hobby other than them. But I love to cook. I really love to cook, and I try to cook something interesting every week. I love to bake. I like to make pies and interesting desserts and make all sorts of kinds of ethnic food. I love to read books, and I love to hike. Those are my major forms.
Well, next time we'll have an interview at your house so we can get some gourmet foods going as well. Right. My final question to you, Liz, is if you could go anywhere in the world, where would you go?
Oh, for what purpose? To work
for
or
fun.
To live?
For
fun? Oh, that is a hard one. I'd go someplace where I could walk a lot, like the Black Forest of Germany. I've been there walking before. Or I love to go to Europe, and I might just go there and hitchhike around.
Well, I think that they would certainly welcome you with open arms, knowing who you are and what you've done for so many of our patients. And, I think very few people actually realize that pathologists actually do make a difference in our world.
Yes.
They certainly have helped us to treat patients and to get them better.
Right.
And nowhere in medicine, in heart transplantation, do you take somebody literally at death's door and they walk out the front
Right.
door
I
of the
know.
hospital. And
It's
certainly,
truly
Liz,
remarkable.
you have had a great impact in our field, and certainly not only myself, but my colleagues and the patients, heart transplant patients of the world, have a lot to owe to you for what you have done.
Thank you very much, John. I appreciate that.